Boa noite a todos, sejam bem-vindos ao webinar Lançamento Nacional da linha Schelin CoreFlow, da empresa Prostland na Suíça. Meu nome é Áurea Farias, eu sou gerente nacional da linha de urologia da empresa HDL Medical, e é um prazer hoje estar com vocês nesse evento maravilhoso. Conosco hoje está presente o Sr. Svecker, que é o nosso agente de desenvolvedor de negócios no exterior. Com a palavra, Svecker.
Yes, good evening, everybody. Thank you for your attention. So my name is Sverker. On behalf of Prostalund, it is an honor and a pleasure to open up this educational webinar on the innovative technologies of Prostalund through the Schelin and CoreFlow devices to enhance BPE treatments onwards. And so the way we would like to set up the meeting is first to introduce the CEO of the company of Prostalund, Johan Wennerholm, to give a short presentation about the company, because the company has been around for years, working with minimally invasive BPE treatments, but is now addressing the worldwide market with its innovation. And then after that, I will give the word to Dr. André Cavalcanti, who is a consultant urologist in Rio de Janeiro, who is an authority and a reference for minimally invasive BPE treatments in Brazil. And he will moderate the scientific session, which will involve two different presentations, one by Dr. Gianpaolo Siena from Florence in Italy on the Schelin Catheter, and one by Dr. Sonny Schelin on the CoreFlow catheter. Hope that everybody will enjoy. And I just wanted to say also that we may not be in a position to have time for all the different questions. So please feel free to send your questions on the chat. And the questions that we don't have time to answer, we will come back afterwards individually to answer those questions. So, Johan, the word is over to you. I think you have a presentation to share with us about the company that you're heading.
Yes, thank you very much, Sverker, for the introduction. And I have made a presentation of 6 slides. And we are from Lund, and we are working with prostate. So the easy name of the company is Prostalund, and we are located south in Sweden. We are Swedish medtech, and we were established in the mid-90s. So we were pioneers with our method CoreTherm, which is heat ablation treatment for BPE. We are still focused on that, and we have around 30 clinics in Sweden and Scandinavia these days. And we have been focused on the Nordic countries. Our treatment concept is that we measure the prostate, and then we do an individual treatment for each patient. The whole concept that we have is developed over 25 years, and it has been fine-tuned. We have studies, I will show later, that show that we have the same result as TURP surgery. There is one big difference comparing to TURP. We do this in local anesthesia, and we have no limit in treatment. We can go up to 400 cc of the gland. The whole concept is evidence-based. We have a huge amount of studies. We have a patent for the products, and we are approved FDA, Europe, and in China. the whole concept is based on this machine, and now we have a new CE-marked device where we have put in all the features that we have experienced over the years that we need. We have two endpoints built into the machine, and we can treat up to, as I said before, 400 cc big glands. These are one of the studies where we're comparing our result with TURP, and the big bold is the most interested in this study, and that is that there are no difference between the methods if you're comparing the results. And even more, it's more safe to use our device than TURP or TURP. This is the portfolio, and it's also the concept that we have. So we have one pre-treatment catheter that is called Schelin Catheter, and that catheter is used for local anesthesia, only local anesthesia. Or you can inject which drug you want. It's approved for every drug, but it's a tool. In the middle, you can see the platform together with our treatment catheter, which you connect to the machine and gives heat by the microwave generator. And after a treatment done by CoreFlow, you need a catheter for a couple of weeks. So we have invented our own catheter, and that's a CoreFlow soft stent. And that is a hybrid between a catheter and a stent. But what we have seen, because this is our concept and our method in the Nordic countries, is that the last catheter can be used for other methods. For instance, they can be used in conjunction with Resume, water vapor, green light laser, eye tint, TURP, HoLEP, Urolift. And they can be a diagnostic tool for prostatitis as well. Even if you are using Resume, they need a catheter afterwards. And therefore, we have found out that the CoreFlow soft stent is perfect for that issue, for that areas of use. But you can also use that product to make a diagnostic tool of the external sphincter. So by this, I want to send over the presentation to Andre and then to Dr. Siena.
So, Johan, thank you very much for the presentation. Now we'll start our scientific session, and I give the word to Dr. Andre Cavalcanti to first give an introduction and then to interact and moderate the session on these new technologies to enhance BPE treatments. Dr. Andre?
Bom, boa noite a todos. Gostaria inicialmente de agradecer o convite em participar. Meu nome é André Cavalcanti, eu sou professor de urologia, trabalho no Rio de Janeiro, sou chefe do serviço de urologia do Hospital Universitário Gafrey Guinde, da Universidade Federal do Estado do Rio de Janeiro, e trabalho basicamente com cirurgia reconstrutora urológica e funcional. Bom, esse seminário é bastante interessante. A gente observou no passado, na década de 90, o surgimento dos tratamentos medicamentosos para HPV, como opção ao tratamento cirúrgico, que na época basicamente restringia-se às ressecções de próstata transuretrais com energia monopolar e as prostatectomias abertas. Mas a gente observou, com décadas de uso de tratamento medicamentoso, que muitos pacientes melhoram dos sintomas, mas eles continuam obstruídos, e essa obstrução pode, a longo prazo, causar alguns problemas funcionais na bexiga. A gente também observa que muitos pacientes têm medo de se submeter ao tratamento cirúrgico pelas possibilidades de complicações e de sequelas, e que acabam postergando tratamentos cirúrgicos, utilizando tratamento medicamentoso, muitas vezes inefetivos por um longo período. E muitos não toleram tratamento medicamentoso, sejam por efeitos colaterais sistêmicos ou relacionados à sua vida sexual. Dessa forma, procedimentos novos que diminuem os riscos de complicações são cada vez mais importantes e mais interessantes nesse cenário de uma população que envelhece e, consequentemente, aumenta a taxa de necessidade de tratamento relacionado à hiperplasia prostática benigna. Os tratamentos cirúrgicos, eles evoluíram com o tempo. A gente saiu do tratamento da cirurgia aberta e da ressecção monopolar para a ressecção bipolar, para o uso do green light, que é a vaporização, para o uso das enucleações a laser, com o HOLEP, com o túnio e o rômio, diferentes tipos de energia a laser. A própria cirurgia robótica trouxe a prostatectomia aberta tradicional para o cenário da cirurgia robótica, mas, sem dúvida, o que vem nos interessando bastante são as terapias minimamente invasivas para a próstata. E aí a gente tem o Resum, que é o vapor de água, de energia pelo vapor, com ablação pelo vapor, o Urolift, que é o lift uretral, como já foi falado inicialmente, a energia de micro-ondas para ablação de próstata também parece ser bem interessante, e o iTind, que também é uma tecnologia minimamente invasiva. Disponíveis hoje no Brasil, para que isso seja colocado dentro do cenário de aplicações, nós temos o Urolift, nós temos o iTind, e a gente tem o Reso num processo de aprovação, provavelmente estando disponível para a prática dos urologistas brasileiros no decorrer desse ano. Dessa forma, essa noite é bastante interessante, que a gente vai ter a oportunidade de aprender sobre duas novas tecnologias que podem ajudar ao tratamento e ao manejo da hiperplasia prostática benigna, tá? Que são os catéteres, né? O catéter de Schelin e o CoreFlow e o Stent CoreFlow. Então, eu fiquei muito interessado desde a primeira vez que eu vi, inicialmente com a Áurea, já lá no Congresso Paulista, né? Fiz alguns questionamentos sobre os catéteres, e agora a gente tem a oportunidade de participar de um seminário. Então, gostaria inicialmente de introduzir os dois apresentadores, o Dr. Siena, de Florença, na Itália. Ele vai falar sobre o catéter Schelin, e o Dr. Schelin, que é, na verdade, o inventor de ambos os catéteres, vai falar sobre o uso do CoreFlow Soft Stents. Também uma opção bastante interessante, tanto para pós-tratamento, como para manejo de retenção urinária e também para alguns testes terapêuticos. Então, vamos iniciar com o Dr. Siena, que vai nos falar sobre sua experiência com o catéter de Schelin. Dr. Siena, por favor.
Okay. So, good evening, everybody. Thank you for the kind invitation. I think you can see the video. Is my video shared? So I will talk about the Schelin Catheter. That is this new tool that can be in the armamentarium of the urologist in this in the field of the minimally invasive surgical treatment. That is very appealing for all urologists at present. And since there's been a trend towards the use of these technologies, as Dr. Cavalcanti previously described, in the urological field. There's a constant increase in the use of minimally invasive surgical treatments in urology. So the Schelin catheter is a catheter, as you can see here in this image. It allows sterile intraprostatic injection of an anesthetic drug or other drugs. The area of use is a local anesthesia delivered transurethral before water vapor therapy, prostatic urethral lift or ITIN. Other potential area of use at present, there are only anecdotal cases reported in the literature and can be adopted in case of green laser procedures together with light sedation with midazolam. There's also a case report on HOLEP and TURP together with light sedation with midazolam. Future perspectives could be delivery of therapeutic agents or diagnostic agents, so a theranostic application. This is the catheter. As you can see, is a 3-ports catheter, is a standard 3-ports catheter with a drainage outlet, port for the needle that is a retractile needle. This needle is flexible at the tip. It comes out the catheter before the balloon, has a 30 degrees angle with the catheter, and is long, and it comes out the catheter for 4.5 centimeters. The third port is the standard balloon inflation valve. Importantly, at 12 o'clock position, there is a mark that indicates the 12 o'clock position. The catheter is shaped with a curved tip, almost like a Tiemann catheter, in order to go through prostate with third lobes, for instance. As we know from the anatomy, the most innervated area is the posterolateral aspect of the prostate, where the neurovascular bundle runs. And this is in 60 to 70% of the cases. The majority of the innervation of the prostate is at the posterolateral aspect. 20–30% of the nerve fibers are also found at the anterolateral aspect of the prostate, and in very few cases also at the level of the base. So when we do the injection of the local anesthetic with this catheter, we have to deliver a major amount of anesthetics at the posterolateral aspects of the prostate, and that is 4 o'clock position and 8 o'clock position. We normally deliver 7 milliliters per lobe, and normally we inject the needle deep into the prostate. We deliver the first 3 milliliters, then we withdraw a few centimeters the needle, we withdraw another 2 centimeters, we withdraw again needle, and we deliver the last 2 milliliters. So the scheme is 7 milliliters per side, and each 7 milliliter has to be fractioned 3 to 2 milliliters. Whereas at the anterolateral aspect, at 10 o'clock and 1 o'clock position, we can deliver 3 milliliters in one single shot. As we can see, I have a video here to show you how it works. And you can see an animation of the catheter. This is the catheter. Of course, we introduce the catheter into the bladder. You can see the animation on the picture on the left-hand side. We inflate the balloon in order to void the bladder stretch the catheter to the bladder neck in order to be sure that the catheter is at the level of the bladder neck. At this point, we can flush and irrigate the bladder to see that is in place. So a syringe of 20 milliliters of 1% mepivacaine or lidocaine is injected. As you can see in the animation, now we are injecting the posterolateral aspects of the prostate at say the left-hand side. We do the first 2 milliliter shot and then the last 2 milliliter shot. So we can use the marked arrow. You can see a marked arrow at the entrance of the catheter that shows us where the needle comes out. So we inject on the other side the 7 milliliters fractioned, as we said, and then we can go at the anterolateral aspect, inserting the needle in and injecting the 3 milliliters at 11 o'clock. Then we can insert the catheter again, stretch it, and we know that according to the arrow, you can see at this level. We can inject on the at 1 o'clock the last 3 milliliters. The procedure is really simple. It takes 3 minutes to do. Once the procedure is done, you can deflate the balloon, remove the catheter, and at this point enter with the resume device, navigate into the urethra. This is the aspect. This is what we see after the procedure. There's no bleeding. There might be minimal bleeding, but normally you can flush it with the port to the third port. You can see a tiny ecchymosis at the level of the prostate, and at this point, at this time, we can infiltrate the water vapor into the prostate. So we can go on with the presentation. So at present, the Schelin Catheter has a very wide experience in Sweden and the Nordic region, especially with the core term therapy with TUMT. Over 13,000 cases have been performed since 2005. Along with local anesthesia, in case of TUMT, also adrenaline is administered into the prostate. This is done in order to contribute also to reduce blood flow into the prostate, along with a reduced pain due to the local anesthetic administration. This has shortened thermotherapy to today's approximately 10 to 15 minutes. Since 2022, the Schelin catheter has also been introduced across Europe to administer lidocaine or mepivacaine before water vapor treatment, prostatic urethral lifts, and in anecdotal cases, along with light sedation, also in case of the green laser HoLEP and 2RP. Studies in the literature have been published first in 2002 by Dr. Schelin that shows less analgesic and reduced treatment time for TUMT with after local anesthesia. Again, in 2004 and 2009, the author, Dr. Schelin, and co-authors reported a reduced prostate bleeding and perioperative bleeding after 2RP. And 2009, in this paper published by Knudsen, transurethral intraprostatic analgesia the authors reported a reduced need for intravenous analgesic and reduced treatment time, always for 2 minutes. In 2021, Stermark and colleagues reported a larger resection weights in case of 2RP. In 2023, we sought to evaluate this instrument before water vapor treatment. And we published on prostate cancer and prostatic disease this paper, the use of a Schelin catheter for analgesia during resumed treatment of the prostate. So the aim of the paper, the study, was to further enhance the minimally invasiveness of resume. This is like a step forward towards micro invasiveness. So we sought to evaluate the advantages and feasibility of transurethral anesthesia via Schelin catheter. So we enrolled 20 patients with a median age of 67 years, the median prostate size of 75 milliliters, and median Qmax of 9 and median IPSS of 23. So we asked the patients prior to the procedure at 9 different time points to rate their pain on a numeric rating scale from 0 to 10, and 10 being the worst pain. These are the results at the 9 different points. The 9 different points were preoperatively. Of course, the median pain was 0. At the Schelin catheter insertion, at the local anesthesia infiltration, at the resume insertion, at the water vapor treatment, and catheter insertion at day 1, day 7, day 30. The maximum pain, median pain experience was 3. In one case, we had 1 patient reporting 6 during water vapor treatment, but this is probably done due to the we had a problem with the actual resume equipment, so we had to delay the procedure and probably the anesthesia faded away. And so in conclusion, we, in our analysis, our findings were that we had a full pain control during water vapor treatment. We also had a very short operative time because the anesthesia itself lasted, the median time of the anesthesia was 3 minutes. The median time for resume treatment is 6 minutes. So the total procedure required 9 minutes. An interesting finding was the potential reduction of postoperative discomfort of the catheter. This might be due to the preemptive analgesic effect of the local anesthesia. Of course, when performing a procedure in the outpatient setting, we have a faster recovery time. This technique can also increase the use of, and we can widen the indication to the resume treatment, also for patients not suitable for mild general anesthesia. More feedbacks come from my colleagues. There's Dr. Cindolo. He did a green laser with the only use of Schelin catheter, and Professor Giovanni Ferrari, he performed the HOLEP with the use of the Schelin catheter. So, thank you for your attention.
So I believe that we can move to Dr. Schelin presentation, and then we can discuss a little bit about both procedures. Okay. Dr. Schelin. Okay.
Coming. Yes. Thank you for inviting me to do this presentation. As I'm the inventor of these two products, it's an honor for me to participate and share my experience. I'm supposed to talk about the CoreFlow soft stent, which is an innovative product. Next, please. You know, it's a catheter stent. As you see in the upper part of this picture, it's just like an ordinary Foley catheter and can be introduced and used for different long time as an ordinary catheter. If you look at the left side of the picture, you will see here there's a blue thread coming out, and it goes inside and connects the two parts. The stent part and the outer catheter part are stuck and could be used as a catheter. When you release this part, and then you can move this outer catheter part away, and then you will activate the stent. You see this is the stent part, and here the external sphincter is supposed to close. And you see this coil of this tiny silicone tube will prevent the stent to move inwards to the bladder. Next, please. So the intended use for this is a temporary stent, and the meaning was to give a good alternative to an indwelling catheter after our core-time treatment. So it was invented, and it has been used since many years as an alternative to an indwelling catheter after minimally invasive TUNT treatment. Next. So the areas of use, you can use it in retention situations, in acute retention, and in connection to chronic retention, patients unable to pee or having an incomplete bladder emptying. And as we have used it in Sweden, it's mostly just waiting for an active treatment. It's not a definitive solution of the patient problem. But in some cases, as Dr. Sienna mentioned, the waiting time for surgery is very long, up to 1 year or even longer in Sweden. So I had a few patients with where when I had to change the stent up to 11 times waiting for surgery, and they were very happy, having much less discomfort than using an indwelling catheter. We have used it since 2005 after our core-time treatment, and as an alternative to a catheter. But you know, there must be younger apt people too that can cope with the handling of this stent, and old, sick and incompetent patients, I think it's easier and better for them to have an ordinary catheter inside. But the most interesting use of it is it's a diagnostic tool. You know, patients with neurological diseases like Parkinson's disease, stroke history, patients with spinal injury, patients having in pelvic surgery, it's quite usual that they have some disturbance of the neurological regulation of the micturition. So everybody knows that the Parkinson cases, you risk to get an incontinent patient if you do surgery, and this stent could be used to check the external sphincter. And I do it like this. I install saline into the bladder until the patient have a very strong urge sensation. and then he must go around in the office for some 10 minutes. And if he's continent with the stent in place, keeping the internal sphincter open, then I'm sure that the external sphincter will be competent, and I can go for an operation or a short term or any active treatment. Another kind of patients that could be interesting to do this easy urodynamic examination in the office is the patient with a long-standing catheter care, unable to pee themselves, and then you can mimic the situation after a TURP or a short term or whatever. If you put the stent in, that will keep the obstructive part of the prostate open, and if the patient is able to initiate the micturition, and if he is able to empty his bladder with a stent in place, you mimic the situation after the obstructive surgery or treatment. And if it works, you can go for an active treatment and be confident that we'll end up with a good result. Next, please. And today we have 3 different lengths of the stent, the 30, 40, and 50 millimeter length. And of course, next, please. Of course, you must then measure the length of the prostate, and that is performed by doing transrectal ultrasound. On the sagittal view, you must measure the distance between the bladder neck and down to the apex of the prostate to choose the right length of the stent. So in general, we go from, if there's a 40 millimeter long stent, I put in up to 40, I put in a 30 millimeter stent, and up to 50 millimeter length of the prostate, I put in a 40 millimeter length, and if it's and so on. So then, if I put a too long stent in, of course, the patient will be incontinent, because then it will have the external sphincter open all the time. Next, please. This is, it looks like an Nelaton Foley catheter, and you just install it the same way. What I would recommend is that you fill up the urethra with 20 milliliters of anesthetic jelly and put the penis clamp in place some 5 minutes before you introduce the catheter, because it's this external tiny silicone tube. You need anesthesia reaching all the way into the bladder and the prostate part of the urethra, and the lubrication must make it very easier to put this stent in place. Next. So when you have removed the outer catheter part, you can see the stent now ending just above the external sphincter and keeping the narrow part of the prostate open. Next. And then the patient can urinate himself spontaneously, and if he is able to void and start the voiding and empty his bladder perfectly, then you mimic the situation after the obstructive treatment. And this we use this as an easy urodynamic test in the office in all patients having a catheter for a long time before we decide to do active treatment. Next. And this animation, could you activate it, Johan? It doesn't seem to work. Okay, we go to for next. Next, please. I lost my presentation. Hello.
Johan,
Johan, could you activate my presentation? Yeah, here you can see when the catheter is fully inserted and the balloon is filled up with 10 milliliters of sterile water, this works just as an ordinary catheter. Next, please. Then you release the locking and outer end of the blue thread, and you can remove the outer catheter part, and then, as you see here, the stent is activated in place, ending just above the external sphincter. Next. And in this situation, the patient can micturate himself. The neuromuscular control, if it's working okay, the patient can activate his detrusor and release his, deactivate his external sphincter and do normal voiding. In the right picture, you can see that this stent can also be used for self-catheterization. If the patient pull the blue thread outside the penis, as you see, the bladder neck will be open and the balloon will be deformed, and you can move the lower part of the stent some 15 millimeters down to open the external sphincter, and then the passage is open. As long as you keep the pulling, there's a free passage of urine from the bladder out. So after court term, I realized sometimes that if the edema is very large, some patients need to pull the thread now and then, the first 1 or 2 days when it's swollen and edematous, and then they can start to micturate themselves. Next. Yeah, next, please. The stent has been used, as I told you before, to do diagnosis of patients with incomplete bladder emptying. Next. And there was a study performed in Russia, 2009, and they had altogether 19 patients with neurogenic disease and incomplete bladder emptying. 8 of the patients had prostatic adenoma, and 11 patients had a normal prostate. So we performed a stent test in all of these cases. Out of the 8 patients with a large prostate, 4 could urinate themselves with the stent in place, and 4 patients could not micturate. They had to pull the thread to empty the bladder. And none of the patients among the 11 with normal prostate could micturate with the stent in place. So you could sort out the cases with an obstruction, and the patients having a neurogenic incomplete bladder emptying could be discovered. Next. So the conclusion is that it's a very simple and quick and easy way to diagnose these patients that could need an active treatment among patients in the neurologic disease history. Next. And I performed a study using the CoreFlow as a kind of pilot study a long time ago. when I used the CoreFlow soft stent instead of indwelling catheter in 51 cases coming. Next. And they had the stent for 3-4 weeks, depending on the size of the prostate. And we performed the quantum concept treatment. And when we finished that, we put the stent in and we flushed the bladder with saline until the return was clear without blood. And we always waited up to 15 minutes after this, the treatment before we activated the stent, and because we wanted to wait longer than the bleeding and the coagulation time to reduce the risk for bleeding and clotting of the stent, and it worked out very nice. And then when we activated the stent, that we first filled up the bladder with saline until the patient had a quite strong urge sensation. And then we separated and activated the stent, and the patient could stand up and void, and then we could check the amount coming out and check the residual urine by ultrasound. And if it worked out, he could leave immediately. And so we could, in some cases, we found that the patient had the wrong length of the stent, and when the patient raised from the bed, he was leaking because we had misjudged the length of the prostate, and then of course he was incontinent, and we have to change to a shorter stent in some cases. But some patients with a very small, swollen and edematous prostate after treatment had to pull the string, the thread, a few days now and then to initiate micturition. Next. So what we learned about this in this first pilot study is that all but one of the patients could have the stent working for 3-4 weeks. One patient had a clotting, I think it was on the 4th day, and we had to remove it. And there was no patient in the whole cohort that had a clinical UTI. And there was only one patient having positive urine culture after stent removal. And we found that, and we think that the voiding, draining, flushing the urethra inside out in a normal way will prevent urinary tract infections, which you often get through an indwelling catheter. And even the patient discomfort was much less with the stent than with a catheter, especially the first 2 or 3 days with the urethral irritation, inflammation by an ordinary catheter. Next, please. So in summary, you could use it in retention, acute and chronic. You can use it after minimally invasive treatments, and you can use it as a diagnostic tool, doing what we call a stent test to check your external sphincter, but also to mimic the situation after an active treatment. And you can, in some cases when the patient don't manage clean intermittent self-catheterization, you can have this way to do antegrade self-catheterization for a period. Thank you. That was all I wanted to tell you.
Bob, thank you for the presentations, excellence, and very, very good explanation about how to use both the catheters. So we can start the discussion. I want to ask Dr. Siena. In Brazil, the use of procedures with poor local anesthesia are not so popular. Probably patients in Latin America, they prefer some kind of procedure with the anesthesiologist. So about the Schelin catheter, how it can improve, instead that we are using the anesthesiology with some sedation, how it can improve the postoperative time of the patient in terms of pain. It will decrease the amount of drugs that you need. What's your impression about that?
As I said in the presentation, there might be a potential preemptive effect. The preemptive analgesic effect is the one we have, for instance, when we perform a skin incision for open surgery, and the anesthesiologist ask to infiltrate the skin incision with local anesthesia, where the tube drain comes out the skin to infiltrate that area. Or even in laparoscopy or robotics, there have been papers of preemptive analgesic effects of spraying inside the peritoneum analgesic. This allows the sedation of peripheral terminal nerves, so patients can have a better recovery. They can have less pain after the general anesthesia. And in this case, what we've seen, we've noticed that they have a less discomfort with indwelling catheter. This is probably due to this effect, because there's a long-lasting effect in after the local anesthesia, especially in the first day postoperative.
Great. And we can inject. Do you have any experience to another types of injections? For example, corticosteroids to decrease the edema after the procedures, or do you think about the possibility to use that, especially after the resume?
They all potential. I've never done personally. I don't know about this type of use, but it could be. There's an open field in a way, because minimally invasive treatment attracts innovation. Schelin catheter is an innovation in these terms, and it goes towards what is the it's a must in surgery at the moment, is to be conservative in surgery and to be minimally invasive. So I don't know about the use of injection of other drugs, but of course they can be tested, and I don't see why not to do that.
We have some questions from the chat, and I think that both Dr. Siena, Dr. Schelin can get the answers. First of all, or some people from the company, how many surgeries with the Schelin catheter around have been done around the world? Was the number of procedures already done with this catheter? Any contraindication to use the Schelin catheter, or risk of infection, maybe a prostatitis associated with the injection? And in what countries around the world the catheters already use it?
Well, about the countries in the world, I'll let Prostalund and Dr. Schelin to tell. I can say about contamination, bacterial contamination. No, it's same. I mean, it's the same risk as any catheterization. And actually, if we compare the prostatic block that is done through a transrectal probe, in that case, we might have more risk of contamination through the rectum wall instead through the urethral, and we have pretty much the same risk as we have of any catheterization. For the spread and countries that are using this approach, I'll let my colleague Dr. Schelin and the Prostalund CEO to reply.
I can tell you about the difference concerning effectivity using a periprostatic transrectal block or an interprostatic infiltration of local anesthetics as we are doing it. There is a study from a Japanese colleague, Mutaguchi, some 15 years ago. He did a prospective randomized study in some peculiar way, but he compared the effectivity of the periprostatic and interprostatic block, and it was a clear result that interprostatic anesthesia was much more effective than a periprostatic block, because you don't reach the anterior part of the gland when you go transrectally. And if you go inside into the prostate transrectally, I think the infection risk will be much more higher. And I used the Schelin catheter for diagnosing patients with a chronic prostatitis, very hard cases, long history and severe problems with a typical pain situation. And then I performed a local anesthesia, just as we do before the resumed treatment. And if the patient noticed he got rid of his pain immediately, that told me that's prostatitis. It's a non-bacterial prostatitis. But if the patient had the pain still unchanged, I considered that it was a chronic pelvic pain and not coming from the prostate gland. So I use this at a diagnostic measure. But I think Johan knows about the distribution, the using of the catheter in different countries.
Yes, the Schelin catheter has been used over 13,000 times. And what is more impressive is that there is no adverse event through those 13,000. And where is it used? It's used all over Europe right now. Italy, Spain, UK, Austria, Holland, Poland, Norway, Denmark, and of course Sweden. And there will be 2 abstracts at AUA in Chicago, where Dr. Siena has 1 abstract sent, and Dr. Shaw from Hong Kong will present the others.
Great, thank you. Let's continue with the questions. So one question for Dr. Schelin. How is the frequency to use, or how is the frequency that's necessary to use this self-catheterization maneuver after a procedure like a Resum or the microwave, and how long it will be necessary? Dr. Schelin?
When we are doing our short-term treatment, we never have a urinary culture before treatment in an ordinary patient, but all catheter cases will have a culture performed some 5-7 days before. And we, of course, do treatment according to resistance pattern to start 2 days before our active treatment. But what we do, we have found that we have cases with epididymitis after our CORTAM treatment. So in Sweden, everybody uses vibramycin or doxycycline for these patients, and we have reduced the frequency of epididymitis to almost nil after using the doxycycline. It's very good because it has some big advantages. It is a high concentration inside the gland, and it has a good pattern against germs, and there's no resistance contamination to the other kinds of antibiotics. You never risk to induce resistance for the ordinary kind of medications.
And can you talk a little bit more about the self-catheterization with the CoreFlow? When you use that, and how frequently is that used?
If I have a young patient with a normal life, active and working and so on, and is apt to do the maneuver, because I think you must cope with it in a good way and understand how it works and to make it functionate. But I have several cases where I have used the stent instead of a catheter, waiting for an active treatment. And the patient, some of them are so happy with this that they won't have the operation after a time. So, but in most cases, of course, it's working very nice, and it's durable for 4 weeks, and then you have to change it for, it's a temporary stent. It's not allowed for more than 4 weeks.
Okay, another question. I have I believe that 3 questions to finish with my curiosity about the products. So you always use the transrectal ultrasound to measure the length of the, or you can use another image method as MRI, or basically is transrectal ultrasound?
Yes, of course, you can do that. MRI is perfect, and I think transabdominal ultrasound is difficult to measure exactly good. Perhaps I never tried it, so I can't tell you for sure. But I think the easiest and best way is to do a TRUS exam.
Great. If a patient will need to stay with the CoreFlow for a long period of time, waiting surgery, is not a patient that can go to the surgery, what's the frequency to change? 1 month, 2 months, 3 months? Is the same of protocol for any regular Foley catheter, or you need to change with more time or less time?
No, in my experience, it works the 4 times every time. If you use it after a procedure, there is an increased risk of clotting, and that the stent will be dysfunctional. But in the ordinary cases with retention, I never see that problem. It's not, if you don't have a chronic proteus infection or whatever, there is risk for bladder stone formation, and the growth on the surface of the catheter is nil, I think, because the time for it inside is only 4 weeks.
Oh, okay. And any study compare patients that uses the Foley catheter and then change through the CoreFlow catheter about the quality of life, or there are any study regarding this?
No, in Sweden, this stent was introduced 2005, and I did this short pilot study, as I showed you, and the Russian colleagues did the test. But after that, we have used it all the time without doing any science. Of course, we should have done that. I understand that now, but I was occupied helping patients all the time.
Okay. So we have more than 1 hour of discussion. Any questions for the audience or for the chat? Then I believe that we can close our work this night. Anything that the company wants to say?
I think I have one comment. The Schelin Catheter, it's not only to anesthetize the prostate. I performed TURP surgery with this anesthesia, and then I installed 2% lidocaine or mepivacaine inside the bladder, the first thing, and then I blocked the catheter, and then I did the 4 injections, as Dr. Sienna showed you. And during the time I performed the anesthesia of the prostate, the inside the bladder was anesthetized. So in my opinion, it's a bladder and prostate anesthesia.
So just one, my last question I forgot. The protocol of the use of adrenaline to decrease the bleeding after during the prostate procedures. How is your experience? How is the protocol to put the adrenaline inside the prostate, and how you believe that it works, and how much decrease the bleeding?
The combination of local anesthesia and adrenaline give you 2 big advantages when you do the quantum concept treatment. You have a good anesthesia, never need any injections of sedation or whatever. And my patients are driving the car home themselves directly after they leave, within 1 hour after they come, and they drive the car home themselves. And this is the regular way to handle it since many years. And the adrenaline shuts down the intraprostatic blood flow in the same locations inside the prostate, according to the British pathologist Clegg. He showed where the blood vessels and nerves enter and leave the gland, according to the picture Dr. Sienna showed you. And if you do adrenaline injections, you shut down the prostate blood flow almost to 0. And then heat goes out the same way in every patient, because the heat is transported away with the blood flow. So you can reach the same treatment situation in every patient if you block intraprostatic blood flow. And what we learned is that the treatment before we started to do adrenaline injections, it was 1 hour treatment time. Now it's 8 minutes as a mean time. So it will fasten the treatment enormously if you block the intraprostatic blood flow.
So, Dr. Sienna, and any final comments? Any consideration and final comments?
Well, of course, the history is there. I mean, it's in the literature, but what is interesting about this device is that there are several future applications. And because I believe that minimally invasive treatments are here to stay, there are so many available at the moment, and they are most of them are of not only interest, but are becoming an important option for patients, because there are a midway between definitive surgery and the medical therapy. The use of this, the local anesthesia in this case, is it can be a game changer in a way. It can help to fasten, speed up the procedure. It can help to shorten waiting list. And of course, there's a field for several different applications, and that we will probably discover in the future, like delivering local drugs, for instance, for therapeutical purposes.
Okay, I'd say thank you for Dr. Siena, Dr. Schelin to participate on this meeting. I'm very impressed with the catheters, both many applications, as you told, for the surgery, and I'm very interested in the diagnostic applications for the catheters. So thank you. I hope to see both in Brazil in the future, coming to our meetings and to talk about these new technologies. If the company has something to tell and to finish the meeting,
I'd like to thank you, Dr. Ande, for excellent moderation, and thank you for excellent presentations. I think this was very practical, very, very clear about the usage, and which is not so easy always with such innovative products. So I would like to thank everybody for a really excellent educational session. And I leave the word to Aurea para terminar, encerrar com algumas palavras em português.
Doutor André, palestrantes, nossa, foi um prazer, a aula foi maravilhosa. Fiquei muito contente com o resultado de tudo que foi apresentado. Não há mais perguntas. Houve, sim, algumas necessidades que serão apresentadas no próximo evento, que está com data para o dia 8 de maio. Quero já aproveitar e confirmar a presença de todos aqui, tá? Hoje nós tivemos um número bem expressivo de pessoas que se inscreveram para esse evento, então despertou muita curiosidade. O Johan, que não está presente, né, o Gohan, que não está presente, e o Svecker estarão presentes aqui no Jornada Paulista, e também no Congresso Brasileiro de Urologia no final do ano, com a gente. O material ele já se encontra disponível aqui no Brasil, inclusive para iniciar cirurgias testes, não há problema algum. A Gadali já coloca à disposição até do doutor André. Podemos ir ao Rio de Janeiro para acompanhar o procedimento de perto contigo. Tá bem?
Tá ótimo.
Doutor Schelin, muito obrigada. Doutor Siena, muito obrigada. Doutor Johan, também muito obrigada. Svecker, sem palavras, gratidão realmente, viu? Um grande trabalho, foi uma ótima apresentação.
Trabalho seu, tá? Tá ótimo. Thank you very much, everybody. Lovely, and looking forward for the next time when we get together. Thank you. Have a good evening.
Thank you. Bye-bye. Good night.
Bye-bye. Thank you.